Hey there, CyberMDs, and welcome to another lecture for our USMLE Step 2 Cardiology lecture series. In this lecture, we're going to be covering valvulopathies. Before we begin, please remember to like, comment, and/or subscribe so that we can continue to provide free medical education to students everywhere. On this slide, I've just provided a brief lecture overview, so feel free to pause, take a minute, and read this if you feel like you need it. Alright, so let's get started with a brief introduction. First, let's talk about murmurs for a second. Murmurs are going to be those abnormal heart sounds that you hear in your stethoscope, and those are going to arise from turbulent blood flow within the heart, which can be due to various reasons, but that can include valvular abnormalities, which is what we're talking about today. And so there are two primary types of valvular issues that are going to lead to murmurs, and those are going to be stenosis and regurgitation. Stenosis is going to be when the heart valve doesn't fully open due to a stiffening or thickening, and that's going to restrict the blood flow. That turbulence created by that narrowed valve is going to result in a very specific type of murmur. On the other hand, regurgitation is going to be when that valve doesn't close properly, and that's going to allow blood to flow backwards within the heart. And that backflow is going to create a different pattern of turbulence and consequently a very different pattern of murmur. And so it's also crucial to understand that not all murmurs are going to be indicative of pathology. And some murmurs are going to be benign and they're not going to signify underlying heart disease. And that's going to be essential for you to distinguish in clinical practice. And so when we hear these murmurs, oftentimes these murmurs are graded on a scale from 1 to 6 based on their intensity. So grade 1 is going to be barely audible with your stethoscope, even if you're in a quiet room, if you can even hear it at all. Grade 2 is going to be heard immediately after placing the stethoscope on the chest, but it is going to be quiet. Grade 3 is going to be moderately loud. Grade 4 is going to be loud, but with a palpable thrill. So when you place your hand on the patient's chest wall, you will be able to hear or feel, that murmur and the thrill that it is causing. And grade 5 is going to be a very loud murmur, and you can actually hear it with your stethoscope just slightly off of the chest. And then grade 6 is you're going to be able to hear this without the stethoscope even being close to the chest. This is going to be an extremely loud murmur. And so the grade of the murmur is going to provide valuable information about the severity of the murmur. And you will find that while murmurs are graded and knowing the grading can be helpful for you on your exams to assess the severity of that patient's murmur on your exam, that the utility clinically is going to vary by not only specialty, but by provider as well. Lastly, let's talk about the importance of echocardiography in diagnosing these patients who have valvulopathies. So it's going to be the cornerstone of diagnosis. And again, this echocardiography is ultrasound of the chest, and it's going to use those ultrasound waves to create images of the heart. And that's going to allow us to have a very detailed assessment of the heart valves and the blood flow through them, which are going to be the two critical aspects of echocardiography in valvular diseases. So in valve assessment, it's going to provide a visual and quantitative analysis of the valve anatomy and the valve function, which can help in identifying abnormalities like thickening, calcification, or prolapse of the valve leaflets. And then flow assessment is going to allow us to evaluate the speed and direction of blood flow through the heart, which is going to be crucial in assessing the severity of stenosis and regurgitation. So first, let's talk about mitral stenosis, and let's talk about the etiologies of mitral stenosis. The most common cause of mitral stenosis is going to be due to rheumatic heart disease, which is going to result from an autoimmune reaction to that group A strep infection, which is going to lead subsequently to chronic valve inflammation and scarring, and that scarring eventually causes the mitral valve to narrow and to stiffen. You can also have mitral annular calcification, and that's going to be a degenerative process more common in the elderly, where those calcium deposits form on the mitral valve leaflets or annulus, leading to stenosis of the valve itself. You can also have radiation therapy causing mitral stenosis, typically going to be a patient who has had radiation in their chest area. and that's going to be a very late complication, but that radiation can induce fibrosis and calcification of the valve. And then you have some other uncommon causes, such as Fabry disease, maybe an endomyocardial fibrosis, maybe lupus. And while those causes are rare, they can contribute to the development of mitral stenosis through various pathological mechanisms, which I will leave up to you to read about in your spare time. And then, as far as signs and symptoms of mitral stenosis go, patients can present with fatigue or weakness because they're going to have a decreased cardiac output. They can have palpitations due to AFib, which is a complication possibly of mitral stenosis. They can present with chest pain, especially during exertion. It's not going to be anginal in nature, but rather due to pulmonary hypertension and right ventricular strain. And then finally, they can have fluid overload symptoms as that left atrium enlarges and the pressure backs up into the pulmonary circuit. Again, these patients may develop symptoms of fluid overload, such as shortness of breath, orthopnea, or paroxysmal nocturnal dyspnea. So those are all things to think about as possible signs and symptoms of mitral stenosis. All right, so let's talk about some of the auscultation characteristics of mitral stenosis. You could have a loud S1, and that's going to be because of the increased force required to open the stenotic mitral valve during diastole. You could have this early diastolic opening snap. So following the closure of the aortic valve, an opening snap will be heard in early diastole, and that's going to be produced by the abrupt halting of the mitral valve's leaflets due to the motion of that stenotic valve. And then you could hear this low-pitched, crescendo, decrescendo, rumbling, diastolic murmur. And the hallmark of mitral stenosis is going to be that diastolic murmur. It's best heard at the apex of the heart using the bell of the stethoscope, and the murmur typically, again, starts low-pitched and crescendos towards the middle of diastole, and then decrescendos as diastole ends. Now, how do you diagnose this? Again, back to the beginning of the lecture, you're going to diagnose this with echocardiography or transthoracic ultrasound. Your treatment options are going to include diuretics, and then you may or may not see these patients with beta blockers or calcium channel blockers as well. Medical management is going to involve the use of diuretics to reduce pulmonary congestion, and then beta blockers or calcium channel blockers may be used to control the heart rate, especially in patients with concomitant atrial fibrillation. You can also see patients who have atrial fibrillation as well as mitral stenosis on anticoagulation for that AFib. So these patients will develop AFib due to the enlargement of the left atrium, and then they will have to be anticoagulated in order to reduce the risk of thromboembolic events. You may also see patients who receive surgery for treatment of their mitral stenosis, and that could be a commissurotomy or valve replacement. And for patients with symptomatic severe mitral stenosis, we're going to be doing these surgeries. Essentially, what you're doing is either, as I said, valve replacement, essentially replacing the entire valve, or you can do this commissurotomy, where if you have this thickened commissure of the valves or like around the annulus, you can basically go in and remove some of that tissue, and that will help with the patient's condition. And then also the decision to intervene in these patients is going to be based on their symptomatology and their echocardiographic findings. And intervention is going to be indicated when the pulmonary artery pressures reach very significant levels, often over 25 millimeters of mercury, or often even in excess of 50 millimeters of mercury. And then patients may become symptomatic with exertion or develop signs of right heart failure, and that would also be a time in which we would intervene on a patient with mitral stenosis. All right, next let's talk about mitral regurgitation, which is going to be that backward flow of blood from the left ventricle into the left atrium during systole. And so this condition can arise from various etiologies, including papillary muscle dysfunction or rupture, which may occur secondary to ischemic heart disease or a myocardial infarction. Patients can have infective endocarditis, and that is going to lead to mitral regurgitation by damaging the mitral valve leaflets or their supporting structures. Patients with rheumatic fever are at risk for developing mitral regurgitation. That untreated streptococcal infection can cause chronic damage to the valve. Patients with myocarditis and inflammation of the myocardium can have mitral regurgitation, which is indirectly affecting the mitral valve function by altering the geometry or the shape of the left ventricle as a whole, and therefore its relationship with the mitral valve. And then again, myocardial ischemia can lead to complete remodeling of the left ventricle, again affecting that shape, that geometry, the mitral valve apparatus, and that will result in regurgitation. And a lot of the signs and symptoms will be similar to patients with mitral stenosis. So patients can have palpitations and also irregular heartbeats due to AFib, and that's going to be a complication of mitral regurgitation. They can have orthopnea whenever they're lying flat, and that would indicate fluid accumulation in the lungs due to this left-sided heart failure that's created. They can also be dyspneic or short of breath, especially during exertion. That's going to be another hallmark symptom of heart failure resulting from mitral regurgitation. They can also have signs of cardiogenic shock. So in severe cases, mitral regurgitation can lead to this cardiogenic shock. And remember, this is going to be characterized by inadequate circulation of blood due to the heart's inability to pump effectively. And that's going to be often a consequence of acute or severe mitral regurgitation, such that the resulting, or such as from a papillary muscle rupture. So you have this very sudden onset, very severe mitral regurg that is allowing this cardiogenic shock to progress. And so understanding these etiologies and symptoms, as well as the timing, can be really important for forming your differential whenever you see patients who have mitral regurgitation or patients who you suspect are in cardiogenic shock. All right, so let's talk about the auscultation characteristics for mitral regurgitation. So this is going to be a holosystolic murmur, and that's going to be beginning with the first heart sound, and it's going to extend up to the second heart sound without any gap, without any stop. So holosystolic, pansystolic, lasting all the way through systole. It's going to be best heard at the cardiac apex, which again is going to be located in that fifth intercostal space, typically in the midclavicular line or a little bit more lateral to that. You may hear a soft S1 due to the premature closure of the mitral valve, and then the S3 may be present, or an S3 gallop may be present, and that could be indicative of increased left ventricular filling, as that may be present as well. And then this is especially true in patients who have cases of significant regurgitation, leading to, again, that volume overload. So you'll hear that S3 as the left ventricle, is just overfilled. Diagnosis, again, is with echocardiography, and this could be done with transthoracic echocardiography. However, sometimes transesophageal echocardiography is particularly useful to obtain images in patients where you can't obtain good images with transthoracic echocardiography. And so that's going to provide you a very detailed view of the mitral valve, and is also going to be essential for evaluating patients with suspected endocarditis or valvular thrombi. So remember that if you need to look at the mitral valve and you can't get a good look through transthoracic echocardiography, you can get a pretty good view using transesophageal echocardiography. So in patients who have secondary causes, you can talk about medications versus surgery for treatment. So in cases where the regurgitation is secondary to conditions like left ventricular dilatation, the decision between medical management and surgery is going to depend upon the patient's symptoms, their left ventricular function, as well as the severity of the regurgitation. And then you have to weigh the risks and benefits of surgery. As well as, or in addition to this, you also have to think about anticoagulants, again, for AFib. So patients with regurgitation can also develop AFib, and in patients with AFib, we know we typically want to anticoagulate these patients to reduce the risk of thromboembolic events. And then you can also provide loop diuretics for symptoms, especially in patients who have developed heart failure symptoms, such as the dyspnea or edema. This can be used to reduce the volume overload and alleviate the patient's symptoms. All right, before we move on from the mitral valve, we have to talk about mitral valve prolapse. So the most common cause of mitral valve prolapse is going to be the myxomatous degeneration of the valve leaflets and the chordae tendineae. This degeneration leads to the stretching and thinning of the valve leaflets, resulting in their prolapse into the left atrium during systole. Other etiologies of mitral valve prolapse can be connective tissue disorders, such as Marfan syndrome. And remember, in Marfan syndrome, this is going to be a disorder that affects the body's connective tissues, leading to longer than normal arms, legs, fingers, and again, this predisposition for mitral valve prolapse. Ehlers-Danlos is going to be another group of disorders that affects connective tissues, primarily the skin, joints, and blood vessel walls, but also can be linked to mitral valve prolapse. And then osteogenesis imperfecta, which is known for causing brittle bones, can also affect heart valves, including the mitral valve. There are some other idiopathic causes where in many cases we don't really know what caused the patient's mitral valve prolapse, and so that is going to be a possible etiology, is just idiopathic cause we don't know. So as far as signs and symptoms of mitral valve prolapse go, a lot of these patients have a very asymptomatic presentation. The condition is going to be discovered incidentally during a routine physical exam or an echocardiogram for other purposes, looking for something else. Patients can come in with chest pain or dyspnea. They may also have palpitations, syncope, or dizziness, but those are typically going to be less common than the asymptomatic patient. All right, next up, you already know we're going to talk about the auscultation characteristics. And the hallmark of mitral valve prolapse on auscultation is going to be a mid-systolic click. And that sound is produced by the sudden tensing of the valve leaflets and chordae tendineae as they prolapse into the left atrium. Now, the timing of the click can vary with different maneuvers. For instance, it generally occurs earlier in systole with standing due to the decreased venous return, and later with squatting due to the increased venous return. Diagnosis, again, of course, is going to be done with echocardiography, and the patient's clinical presentation, again, may be asymptomatic or palpitations, chest pain, dyspnea, those types of things. Typically, as far as treatment options go, especially for our asymptomatic patients, we're not going to do anything. The treatment just really isn't necessary. Regular follow-up and regular echocardiographic monitoring may be advised, especially if there is evidence of any kind of mitral regurgitation or if there are changes in the patient's symptoms. For symptomatic patients or those with palpitations or chest pain, those kinds of things, beta blockers can actually be beneficial. They're going to help in reducing the sympathetic drive, which can exacerbate the prolapse and the associated symptoms. And then in patients with mitral valve prolapse who end up developing atrial fibrillation, you want to manage the arrhythmia, you want to manage the AFib appropriately, often with anticoagulation. Very rarely in cases where there is severe mitral regurgitation due to the prolapse, or there's going to be evidence of left ventricular dysfunction, you may have a patient with mitral valve prolapse who needs surgical repair or replacement of the valve. But again, those patients are typically going to have something else severe going on where the prolapse has now progressed into a severe regurgitation, and then there's left ventricular dysfunction. All right, we are moving on from the mitral valve. Let's talk about aortic stenosis, which is a condition characterized by narrowing of the aortic valve, which can lead to some pretty significant cardiac complications if it's not properly managed. So aortic stenosis is going to be primarily caused by just generally aortic sclerosis or fibrosis or calcification, which typically is going to occur in your elderly population. And that's just going to be something that happens over time as we age. And the process is going to be similar almost to atherosclerosis, where lipid deposition and inflammatory processes lead to calcifications on the valves. but a little bit less of that lipid deposition and a little bit more of just chronic damage to the valve just over time due to age. Another etiology can be bicuspid aortic valve, and that's going to be a congenital condition where instead of having 3 cusps or 3 leaflets, the aortic valve only has 2. And so that anatomical anomaly can lead to earlier and more rapid progression of valve stenosis. And then these patients with a bicuspid aortic valve are often diagnosed earlier in life because the degeneration occurs much faster compared to those with aortic stenosis or aortic sclerosis and without a bicuspid aortic valve, who have a normal aortic valve. Rheumatic fever, although less common in developed countries, it can cause aortic stenosis in the developing world. And again, that's going to be that group A strep infection leading to inflammation and scarring of the valve. Remember that for signs and symptoms on the clinical presentation, that aortic stenosis makes you sad. So SAD is the symptoms or the constellation of symptoms, syncope, angina or chest pain, and dyspnea that we often see in our patients who have aortic stenosis. And now, while the acronym is SAD, they typically will test you and say that it occurred in the order of DAS. So they'll report maybe a 6-month history of dyspnea and a 2-month history of angina, and they went to the emergency department because they had a syncope. So if you see a patient who has this constellation of symptoms, syncope, angina, and dyspnea, you should think about aortic stenosis, and it should also be on your differential for any patient who syncopizes. And then, in addition to signs and symptoms and clinical presentation, aortic stenosis, as it progresses, these patients may develop signs of heart failure due to the chronic pressure overload and the reduced cardiac output. And particularly atrial fibrillation, but other arrhythmias can also arise due to that left atrial enlargement that happens as that pressure builds up and backflow builds up. And then you get left atrial enlargement and fibrosis, and that can cause AFib and other arrhythmias. Now, as far as auscultation of this murmur goes, you're going to have a hallmark murmur of a crescendo, decrescendo ejection murmur. And so that murmur is best going to be heard at the right upper sternal border, and it's going to radiate to the carotids during systole. And so again, this is a systolic murmur. So as the ventricles contract and they eject blood through that narrowed valve, that murmur is created due to that turbulent flow. And the severity of this stenosis can often be inferred from the intensity and the duration of the murmur. So a louder, longer murmur is typically going to indicate a more severe stenosis. Again, definitive diagnosis tool for aortic stenosis is going to be echocardiography. And then as far as treatments go, let's talk a little bit about the options that we have there. So treatment is typically going to be indicated in symptomatic patients or those with evidence of left ventricular dysfunction. So evidence of left ventricular dysfunction, maybe some of those heart failure symptoms that we've discussed. And then patients who have a reduced ejection fraction where they are not pushing out, they're not pushing out as much blood, their cardiac output is reduced from their left ventricle. That can be a consequence of prolonged pressure due to the overload created by aortic stenosis, and that can be a reason to treat your patients. And then in patients where you're not sure or you think this could be a potential issue, you can actually get exercise testing, and that can unmask symptoms that demonstrate reduced exercise tolerance, which is an indication for treatment in previously asymptomatic patients. Now, your options can be surgical and non-surgical. So the mainstay of treatment for severe aortic stenosis is going to be aortic valve replacement, and that can be done surgically or through a transcatheter approach, and that's SAVR or TAVR for surgical and transcatheter. In transcatheter approach, the TAVR is typically referred to as TAVR. So you may see TAVR in a patient's EMR, and that's what that stands for. They've had this aortic valve replacement done with through a transcatheter approach. And that's also going to be, or typically going to be based on a patient's risk profile. As far as medical management option goes, they're not going to really alter the course of the patient's disease progression, so they're not going to change the aortic stenosis. but it can be pretty useful to help manage the symptoms as well as other comorbid conditions. So oftentimes these patients will be on beta blockers, diuretics for their fluid overload. ACE inhibitors may be used cautiously, especially in patients who you think that there may be some form of cardiac damage or remodeling going on. All right, moving on now to aortic regurgitation, which is going to involve the backflow of blood from the aorta into the left ventricle during diastole. And so aortic dissection can be a cause of aortic regurgitation. And so that tear in the aortic wall, as it descends, there may be this dissection flap that impedes the normal closure of the aortic valve, allowing that blood to flow backwards. Infective endocarditis can be an etiology, as it causes damage and malfunction of the valve, as well as rheumatic fever. You can have trauma or direct injury to the aortic valve or the ascending aorta, and that can result in aortic regurgitation. You can also have some myxomatous degeneration, ventricular septal defect with aortic valve prolapse, especially in children. This can lead to aortic regurgitation. And so your signs and symptoms are typically going to be your heart failure symptoms, such as shortness of breath and difficulty while breathing while lying flat, which is the orthopnea, and then palpitations. And these symptoms are pretty much all going to be due to this increased volume load on the left ventricle and the potential subsequent dilation that it undergoes or experiences. These patients can also have chest pain, and although that's going to be less common than in patients with aortic stenosis, your patients with aortic regurgitation may still have this clinical chief complaint. And then on examination and diagnosis, you're typically going to hear this high-pitched, blowing, decrescendo diastolic murmur. And so that's going to be the auscultation characteristic. High-pitched, diastolic, decrescendo, quote-unquote blowing murmur, and since it's in diastole, that's going to occur after S2. You're typically going to hear this best at the left sternal border, and there is a chance that this radiates to the apex. And the intensity of this murmur also can vary based on the degree of regurgitation and that diastolic pressure gradient between the aorta and the left ventricle. So again, a louder, longer murmur could indicate a worse regurgitation. And so for diagnosis, again, the primary tool is going to be echocardiography, and you're going to get these Doppler images, which is the gold standard for diagnosing regurgitation, which is going to show you this backflow of blood. There may be some additional testing that these patients receive, such as chest x-rays and ECGs and cardiac MRIs, and that can be used to evaluate other things and the extent of cardiac remodeling and to rule out other pathologies. However, remember that the gold standard for diagnosis is going to be an echocardiogram. And then as far as treatment options go, valve replacement is generally going to be preferred over valve repair, especially in these severe cases. And so you have these bioprosthetic valves, which are going to require anticoagulation for 3 to 6 months. And then you have mechanical valves, which typically require lifelong anticoagulation, typically done with warfarin or Coumadin. And so those are going to be your surgical options, and your considerations are between a bioprosthetic and a mechanical valve, depending on the patient's age, their comorbidities, and their personal preferences. Now, outside of surgery, you have medical management options, which is going to include vasodilators, use those to reduce afterload, therefore decreasing that regurgitant volume, as well as diuretics, which is going to help in managing symptoms of heart failure by reducing the preload for the patient. And then also you have nitrates, which are occasionally used, typically, but with caution due to their potential for decreasing the diastolic blood pressure and worsening the regurgitation. So those are kind of your options for medical management as well as surgical management. All right, let's move over to the right side of the heart and talk about pulmonic stenosis, which is going to be characterized by the narrowing of the pulmonary valve, leading to an obstruction of blood flow from the right ventricle to the pulmonary artery. And so etiologies of this can be congenital, and that's going to be the most common form, where the pulmonary valve is malformed at birth, and that can occur as an isolated defect or as a part of a more complex congenital heart disease, such as tetralogy of Fallot. Pulmonic stenosis is a key component of tetralogy of Fallot, a congenital heart defect, remember, that includes 4 heart problems: a ventricular septal defect, pulmonic stenosis, right ventricular hypertrophy, and an overriding aorta. There are other things such as Noonan syndrome and carcinoid syndrome. Those are more rare, but are still things that can cause pulmonic stenosis and things that you should be aware of. As far as signs and symptoms go, the clinical presentation of pulmonic stenosis can be similar to that of aortic stenosis and is often summarized again with the SAD, the syncope, the angina, and the dyspnea. These are all things that can also occur in pulmonic stenosis. However, those things are typically associated with aortic stenosis, as pulmonic stenosis is much more rare and less common. As far as our physical exam findings go, let's talk about our murmur of pulmonic stenosis. So when you auscultate a patient who has pulmonic stenosis, what you're going to get is this harsh crescendo-decrescendo ejection murmur. And that's typically going to be best heard at the left upper sternal border, typically loudest during systole. And the associated sounds, in severe cases, a systolic ejection click may be present, and the murmur's peak may be delayed. Again, for diagnosis, of course, we're going to use echocardiography for this, and patients may also receive additional imaging, such as MRI or CT, to further look at other anatomical details, especially in complex cases or whenever there are pulmonary things also going on. However, diagnosis should always be correlated with clinical findings, and remember that echocardiography is really going to be that gold standard. So let's talk a little bit about treatment options. So often the treatment of pulmonic stenosis is going to improve or is going to be based upon addressing the underlying etiology, especially if that stenosis is mild or asymptomatic. For moderate to severe cases, balloon valvuloplasty is often the treatment of choice, and that procedure involves the insertion of a balloon catheter into the pulmonary valve and inflating it to dilate that stenotic valve. You can also get valve replacement. So in rare cases, particularly when balloon valvuloplasty is not effective or is not feasible for some reason, or in the presence of severe regurgitation, pulmonary valve replacement may be necessary. And so this is going to be more common in adult patients with congenital pulmonic stenosis who have developed complications over a long period of time. And then post-procedural management may include temporary anticoagulation in these patients, especially in cases where a prosthetic valve is placed into the patient. Next, of course, is pulmonic regurgitation, and this is again going to be less common but still significant kind of valvular disease where we have the backflow of blood from the pulmonary artery into the right ventricle during diastole. So it has several etiologies, including pulmonary hypertension, which is going to be the most common cause. And so chronic elevation in the pulmonary artery pressure can lead to dilation of that valve annulus, rendering that pulmonary valve incompetent. You can also have congenital heart disease, infective endocarditis, rheumatic fever, carcinoid syndrome. These are all possible etiologies for pulmonic regurgitation. These patients are typically going to be asymptomatic, and their findings may be very, very subtle. So many patients do not exhibit symptoms at first, but they can progress. So regular monitoring is essential for early detection and management in patients who have high degree of risk factors or who you suspect may be developing this right-sided valvulopathy. And so although they have an asymptomatic phase, they can develop right-sided heart failure symptoms. So as the disease advances, you get these right-sided heart failure symptoms, and that can include this isolated peripheral edema and ascites and an enlarged liver or hepatomegaly. And so patients may also experience exertional dyspnea and fatigue, but remember these are isolated right-sided findings, and so when you auscultate, these patients typically won't have any fluid in their lungs. So speaking of auscultation, on auscultation in a patient with pulmonic regurgitation, you can get this high-pitched decrescendo diastolic murmur that's typically best heard on the left sternal border. And that's typically, again, going to be accentuated with inspiration as we draw more blood into the right side of the heart. So the diagnostic approach is, of course, going to include echocardiography as the mainstay and gold standard. As far as treatment goes, we can do medical management with diuretics, and those are often going to be used to manage symptoms of right-sided heart failure. In the cases of pulmonary hypertension, specific therapies targeting pulmonary vasculature could also be beneficial. And then as far as surgical intervention goes, valve repair or replacement would be considered in the symptomatic patient or the patient with severe regurgitation, especially if it's, again, associated with right ventricular dysfunction or dilation. Very similar themes to the things we saw on the left side of the heart and things we're seeing throughout the lecture. I apologize, I did get a little bit ahead of myself, but I will pause on the second here for a second here on this slide just so that y'all can catch up or take any notes. But here is everything about the auscultation, diagnosis, and treatment options here on this slide. All right, moving right along, we have tricuspid stenosis. So the most common cause for tricuspid stenosis is going to be rheumatic fever. Again, a complication of untreated or inadequately treated streptococcal throat infection. And that inflammatory process, again, leads to the scarring and the deformity of the valve, causing the stenosis. There are other things out there that can cause tricuspid stenosis, such as lupus and rheumatoid arthritis, myxoma or a heart tumor, and metastatic tumors. These are all things that can cause tricuspid stenosis, which admittedly is a more rare type of valvulopathy, but still, again, something worth knowing. So as far as signs and symptoms go in these patients, you can get this neck discomfort and you can see a giant A wave in the jugular venous pulse. So this neck discomfort may be due to increased venous pressure, and this giant A waves are going to be a classic sign, and that's due to the increased resistance against the atrial contraction. These patients can also have hepatic congestion, as the increased right atrial pressure can lead to congestion of the liver and the things behind it or upstream of it within the vasculature. And the patients who do have hepatomegaly may have this discomfort in their right upper quadrant of their abdomen upon palpation or at baseline. Again, you can get peripheral edema in these right-sided valvulopathies, so as the disease progresses, this, again, increased right atrial pressure is going to lead to that systemic venous congestion, and that's going to result in also this peripheral edema that I've talked about, most notably starting in the lower extremities. On auscultation, you're going to get this mid-diastolic rumble, and that sound is produced due to the turbulent flow, again, of blood through the narrowed tricuspid valve during the filling phase of the right ventricle. And so to best appreciate this murmur, you should listen at the lower left sternal border, especially if you have the patient in the left lateral decubitus position. And so that murmur's intensity may also increase with inspiration as we're drawing blood into the right side of the heart, and that is actually called Carvalho's sign. As far as diagnosis, of course, echocardiography is going to be our gold standard. And then for treatment options, we have diuretics, often used to manage the symptoms of right-sided heart failure, that fluid overload that we continue to talk about that may occur secondary to a valvulopathy. You can have aldosterone antagonists. You can have valve replacement, which is going to be rare. Surgical interventions such as valve replacement in tricuspid stenosis is rare, but may be considered in severe cases. Again, especially when there's this concomitant left-sided valve disease or concomitant right ventricular dysfunction. Make sure you have or you take into consideration other things, such as the fact that these treatment options are going to be very individualized because this is so rare. It's going to be based on symptom severity, as well as the patient's other comorbid conditions, their goals, their preferences, and their overall health. And last but certainly not least, let's talk about tricuspid regurgitation. which is going to be characterized by the backflow of blood from the right ventricle to the right atrium during systole. So etiologies can include secondary causes, which is going to be things such as leaflet tethering issues, which is the most common cause of secondary tricuspid regurgitation, and that can be due to underlying conditions such as atrial fibrillation or pulmonary hypertension. You can also have primary tricuspid regurgitation, which is going to be less common, and that's going to be due to things such as trauma or Epstein's anomaly or Marfan syndrome, myxomatous degeneration, rheumatic fever, infective endocarditis. Those are all going to be your less common, quote unquote, primary causes or etiologies of tricuspid regurgitation. So because that valve fails to close properly during ventricular systole, that blood is going to flow backward, and that's going to increase the volume and the pressure in the right atrium and again in the venous system leading up to that. So the clinical implications are going to be very similar to those which we just discussed. You're going to have things such as AFib that can occur, a flutter that can occur. You'll maybe see some of those same neck pulsations and elevated JVD perhaps. You'll see potentially peripheral edema, fatigue, hepatomegaly. All of those things can also occur in patients who have tricuspid regurgitation. Now, as far as auscultation of this murmur, this is going to be a holosystolic murmur, pansystolic, going to last completely all the way through systole. And so it's best heard at the left lower sternal border and is also going to be characterized by its persistence, that pansystole, holosystolic murmur. The intensity is going to vary based on the severity of the disease itself, or the severity of the pathology and how much it has progressed. And again, this is also going to be one of those valvulopathies where the murmur increases with inspiration due to us drawing more blood into the right side of the heart. In some cases, you may hear this systolic whooshing sound, and that represents turbulent flow across the tricuspid valve as well, but it should still be holosystolic or pansystolic. And the presence of a third heart sound, or an S3, can also be heard at times and could indicate significant regurgitation with right ventricular volume overload. Diagnosis, of course, is going to be made with echocardiography, as we've been discussing and has been the theme throughout the entirety of this lecture. Now, as far as treatment goes, you're going to want to treat the underlying etiology. So addressing the underlying cause of the regurgitation is fundamental, and it may include managing conditions like pulmonary hypertension or left heart disease or endocarditis. And then in cases where tricuspid regurgitation is secondary to other cardiac conditions, you would want to optimize the treatment of the primary disease, and that should help reduce the severity of the regurgitation. Other options include surgical intervention with annuloplasty, which involves the surgical repair of the tricuspid valve annulus, and that's often indicated in cases of significant annular dilation. And the goal for that procedure is just to really restore the normal size and shape of the valve annulus, and that's going to reduce those or improve that valve function. Valve repair is often preferred over valve replacement whenever it's feasible. And so that's typically because there are better outcomes and a lower risk of complications if we're merely repairing rather than replacing the entire valve. And then valve replacement can occur in patients who repair is not feasible for them, or they just have this very severe damage, or it's due to conditions like carcinoid heart disease or Epstein's anomaly, something along those lines. And so choices again include these mechanical and bioprosthetic valves, and the decision is going to be based on patient-specific factors. And then finally, if this patient does have fluid overload with their tricuspid regurgitation, we can do loop diuretics or aldosterone antagonists to help really manage that fluid overload and the symptoms occurring because of the fluid overload. Again, thanks so much for tuning in. Please feel free to check out our website, leave us any feedback, and please remember to like, comment, or subscribe so that we can continue to provide this free medical education resource to students everywhere. Thanks so much.